Warm good morning to everyone and thank you, chairpersons. So, today I'll be talking. It's always very difficult to talk after Dr. VC, the stalwart of cardiology in Baroda, has given a talk. So, this becomes more challenging for me. And again, the topic given is the burning topic, LDL-C, exploring the management of LDL-C and the challenges in very high risk ASCVD patients. So, when I got a call from the organizers, Casey was my senior, everyone knows Casey was my senior in college. And he said that, Nirav boss, lipidology pe bolna hai. I said, I am excited because for a cardiology, what else do you need? Lipids, it's like asking Tendulkar ki Ranji khelega, 100% khelega. And then you know how seniors are, R3, R1. They expose you at such times and make you look like, oh boss, सुबह तो ये बोला था आपने अभी मैडम के सामने. Then he gives me a call and said, कुछ नया बोलो. Don't talk on statins. And then I am screwed. I am going to talk on lipids and I'm not going to talk on statins. So basically, I started feeling giddy. Ki boss, don't make a fool out of me in front of a gala audience. What am I going to speak? And did I hear you right? I don't have to speak about lipids, statins. So my feeling was exactly like this. Abba dabba jabba. But then I gathered some courage and I read a lot of articles. I read the guidelines, ACC, ESC, Canadian, and latest, our own Indian fraternity has Lipid Association of India. They are doing commendable work because we know that Indian coronary substrate and Indian lipid parameters are not similar to the Western population. So we cannot blindly follow the ACC, Canadian or European guidelines for lipids. And then I mustered some courage and have put up a 20-30 slide show. Hope I do justice to this and wish me luck. I need your blessings. So I would highlight 3 or 4 points. First important would be the ASCVD risk in the Indian context, majority of which Dr. VC has already highlighted, and we know that ASCVD risk is very high in the Indian subcontinent. Second is statins alone, because 99.9 or 100% of such patients are on statins. So are they enough to achieve the goal, or are we missing the targets? And what are the statistics? And after that, if we are convinced that there is a hope or there is a scope for something newer than statins or other than statins, then what are the molecules? And that is what we would like to discuss. So coming to the ASCVD risk, I think Dr. VC has in his lecture promptly and nicely depicted this, that ASCVD risk is very high in India and the prevalence pattern is increasing in India. We know that coronary artery disease and stroke affects 10 years before compared to the Western counterparts. The younger population is affected and less than 40, more than 25% have MI. And so, is India really becoming the heart disease capital of the world? And I think the answer is yes. So we have a lot of guidelines. I would not go into the details of this, but there is a lot of unmet need. And now what is the unmet need? Because the guidelines are ever changing. We used to have a target of 130 milligram of LDL in the past. Then it was reduced to 100, then it was reduced to 70, and now Lipid Association of India says that if the LDL can go down in select population to 55 or even 50, it is, and in a subgroup 30, then it would translate into better CV outcomes for the future. So every year the guidelines are changes, and therefore what we should know when the guidelines are changes and the targets are not achieved, we should know that what molecules we have with us. The statin therapy is divided into low intensity, moderate intensity or high intensity. Majority of the patients who are for secondary prevention post bypass or post angioplasty are already on a high intensity statin, that is 40 milligram of rosuvastatin or 80 milligram of atorvastatin. And on that, our target of LDL-C should be 70. But in select population, as we said, it should be 50 or even 30. But we know that there are limitations with statin use. There is a plateau effect. So when you double the dose from 10 to 20 or 20 to 40, as you can see, the incremental effect of LDL lowering is not seen doubling. There is a plateau. That is one of the limitations of doubling of the dose of this thing. And with doubling, the incidences of side effects would increase. So even patients on high dose of statin, more than 40% do not reach a target of 70 and less. And these are the patients who come with repeated events. We have seen in our practice patients coming for one angioplasty, two angioplasty, one angioplasty, and then stent thrombosis, and then restenosis, and then bypass, and then forced bypass, again angioplasty. So in a life cycle of that patient, he undergoes 2 to 3 procedures. So if we target an LDL-C less than 70, we can avoid this to some extent. As we discussed, doubling of the statin has little incremental effect, and therefore the guidelines say that ezetimibe is the next molecule to be added. The number of people who are actually achieving the target, if you see the ESC 2019 paper, 27% eligible patients are receiving high dose statin and 33% only achieve lipids. So more than 70% of our population do not achieve the target, and that is where we as physicians have our role to play. The reasons are statin is intolerated, as Dr. VC said, more than 5 to 10% of population have intolerance. There is a residual risk of diabetics in high dose statins. In spite of doubling the dose, your targets are not achieved. And further lowering by a non-statin approach, ezetimibe shows the modest effect. So even on a combination of atorvastatin with ezetimibe or rosuvastatin with ezetimibe, you may have more than 50% of population who do not achieve the targets. And we all know that achieving the target is important. So to summarize, we need to go beyond statins. In selected population, we need to go beyond statins. Because statins typically reduce the level by 30 to 40% max, doubling of the dose only decreases the further dose by 6%. Side effects like myalgias, GI intolerance, and risk of developing new type 2 diabetes is also high, to the tune of 5 to 10%. And target level of LDL-C is not achieved in more than 1/3 of the patients. So now what? So I would like to discuss 3 case scenarios. He is a young gentleman by the name of Abhay. He is a software engineer. He leads a sedentary lifestyle. He has hypertension. And for a non-ST elevation MI, he underwent an angioplasty to RCA. He is on routine therapy, dual antiplatelet statin, and his lipids are LDL-C is 154 on 40 mg atorva with 10 mg of ezetimibe. The second case is of a retired banker, hypertension and type 2 diabetes. He has undergone 2 PCIs in the past 3 years on a rosuvastatin 20 mg and evolocumab twice a week, every 2 weeks, sorry. His LDL-C is 80 mg per deciliter. And the third one is a dancer, a teacher to my kids. She is hypertensive and she is obese. The BMI is 32. And she underwent PCI for a multivessel disease, 2 drug-eluting stents, one in the LAD and one in the right coronary. On rosuva 20 plus ezetimibe 10, she has a LDL-C of 120. So 154, 80 and 120 on a very good therapy. All educated people, adherence is not an issue. Are we happy with this? Is the LDL target achieved? I think no, because none of them are below 70. Which category of the risk they would fall into? I'll show you the ASCVD risk categorization, high, low or very high. Two of them will fall into high and one into very high risk. Do we need to change their lipid medications? And the answer is yes. So what is the way forward? How do we manage these patients? So this is the ASCVD risk assessment. And when you see the first 2, extremely high risk, LDL-C of less than 40 is recommended. That is recurrent events. Once angioplasty, then bypass, then one more angioplasty, in between maybe a small TIA episodes. So these are all vascular events happening very frequently on medicines. Second is very high risk. The LDL-C is less than 55. Target should be less than 55. And in high risk and low risk, it is 70 or 100. Believe you me, if a patient is diabetic and has undergone one procedure, he would be in a very high risk zone, broadly speaking. So our target should be less than 70 and in some patients less than 55. So now what to do? Lower the better, especially in high risk ASCVD patients. So guidelines have clearly depicted this. I will not go into the detail of this because Dr. VC has already shown this slide, and this is strike early and strike strong, because we have seen that right from post PCI period, the advantages of a strong LDL lowering effect is seen in the early weeks also. So all of these patient profiles would require addition of something, and what? So Fata poster Nikla hero, and that hero is inclisiran. This is the molecule of the future. Right now, as Butt Sahib said, the only hindrance is a phenomenal cost, but the insurance companies are, okay with the claim, passing the claims. Some corporates are also passing the claims. And right now, 3 of my patients are on inclisiran. I'll share their profile. So why inclisiran? Because there is more than 61% LDL-C reduction. No molecule, including 40 milligram of rosuvastatin, has 61% LDL-C reduction. It decreases major coronary events by 18%. There is no need, the need for an additional PCI in the same or second vessel goes down by 23%. And PCI in a previous stents goes down by 24%. And over and above these advantages, it is a side effect profile which is very similar to placebo. That means no major side effect other than a prick. So all of the 3 patients, Abhay, Ramesh and Kalpana, should be given an option of inclisiran. My job as a cardiologist would be to give them an option that, boss, you are not on target. There is a molecule. Of course, it would cost this. The decision would be with the patient. But my job is to make them aware of the current therapy available. So now what is inclisiran? Sir has clearly said a lot about that. I will not go into the detail. There is enough trials, enough data regarding the safety and efficacy. I will like to show you my personal experience before I open the session for questions. Mr. J. Patel, he is my real patient. He is a diabetic hypertensive. He underwent CABG in 2012, and after that he had graft occlusion. So he underwent a CHIP PCI with 2 drug-eluting stent with rotablation to RCA in 2022, and difficulty in achieving LDL targets of less than 70 in spite of rosuvastatin 20 plus ezetimibe 10. Both of the sons are in US, and in US, mind you, this molecule is prescribed like the way that we prescribe statins, because it is under insurance scheme. And both of the sons call me one night and say that why my father is not on inclisiran. And at that time, 2022, inclisiran was news to even me. I said, boss, is it available? Then I'll have to search. So they wanted him to be on inclisiran rather than up titrating the dose to rosuvastatin 40 milligram. And the patient is also happy with just 2 shots a year. He does not have to remember to take his medicines daily in the night. He is happy with 2 shots, and that LDL is nearing target. So this is my first patient. The second patient is very interesting case. Mr. Kapoor is a 55-year-old gentleman who underwent PCI to LAD with a 48 millimeter long DES. He was started on rosuvastatin 40 milligram, and that is my discharge medication for most of my patients for the first 4 to 6 weeks. After 6 weeks, I repeat a lipid profile, and then if depending on the target, I either go up or I add an ezetimibe. So during the first week itself, during the first 4 to 6 weeks itself, he developed severe rhabdomyolysis and came with renal shutdown. The CKMBs were in 35,000. My nephrologist got involved, he gradually recovered, and he was switched to inclisiran. He is not on any statin because it would be a contraindication for reinitiate any statin in him. And so far so good. So this is one real life case scenario wherein nothing will help other than inclisiran. The third patient is his son, Mr. Kapoor again. He is asymptomatic, but his LDL is high. He has a strong family history. His father underwent a PCI, so he becomes a candidate for statin therapy. But because of the stress that the family underwent when the father developed rhabdomyolysis and renal shutdown, the boy is not ready to even touch any statin. He said, nothing doing, boss. I will be okay with twice a year injections of inclisiran. And straight away he was put on inclisiran, and more than 50% LDL reduction was achieved. So these are 3 of my patients who are on inclisiran. As a cardiologist, what I feel is this is going to be the molecule of future for select group of patients. It is not for everyone. It is not for all comers. As a clinician, we should know that patients who are at high risk of ASCVD events and who are not achieving their targets on statin plus ezetimibe and now a new molecule, bempedoic acid. This molecule can be afforded. Right now, what precludes its use is a very heavy cost of around 1 lakh per shot. But there are people who can afford this. We saw in the newspaper in this May that, I think sir would have exact data, 37% increase in the people going to Europe for holiday. One family holiday in Europe is 10 lakh. So if I am able to save a cardiac event by 2 lakh a year, I think many patients would not mind it. It is how I put it on plate for them. So this is it. So the takeaway points I would say is that ACS patients like Abhay, Ramesh, Kalpana are very high risk patients and they require an early intensive lowering of LDL-C to targets. The latest guideline recommend LDL-C goal of less than 55 in very high risk patients. PCSK9 inhibitors plus high intensity statin medicine in post ACS patients rapidly lowers the LDL-C levels and reduce the risk of recurrent events. Inclisiran is a first-in-class siRNA for lipid lowering offers. Its advantages are 50% effective and sustained LDL-C reduction, a favorable safety profile similar to a placebo, and convenience of just 2 shots a year. Thank you. If there are any questions, we have 2 minutes.